bladder cancer. We will now be going on to the surgical options in non-metastatic muscle-invasive bladder cancer. Over the years, we've had a lot of debate on what the appropriate approach will be. We've had open robotic techniques, and we've also had intracorporeal, extracorporeal techniques that have been widely discussed. I'd like to invite our next speaker, Mr. Nikhil Vasdev. He's a consultant urologist and robotic surgeon. He's also the associate medical director at Stevenage Hospital in Leicester. So without further ado, Mr. Vasdev will be speaking on robotic radical cystectomy, which some would argue is the new gold standard. Thank you.
Hello, and thank you very much for the opportunity to present at the iTrue UroGRIPP meeting, which is on urology global residents. Very grateful to Pavan Rai for inviting me to come across to talk, and obviously to Dr. Zasim Hamid. My talk today is on robotic radical cystectomy. It's the new gold standard. I'm going to share with you some of my data, how my practice from an open cystectomist is now purely robotic with an intracorporeal reconstruction angle thrown in, and some work that my research fellows in my lab does based out of the UK and the United States, looking at low pressure robotic cystectomy from the cytokine point of view, and also from the point of view of particulate matter data research, which I'll share with you. Robotic cystectomy is very much here to stay. It's certainly it's always happening. There's a lot more needs to be done. Because I think that the robotic technology will be in a very strong position to help our patients with bladder cancer. My center is this hospital, Stevenage, which is located in Rotterdam. We have cash from about 2 million patients. We have an XI system, and hopefully we're getting a system across the country. We do about 350 to about 400 cases per year. We also have 2 robots that we join up. So we put down here, that's 10 AI per week, and put and transit as we work because we use our robots and these things take a week. And we have very powerful. During the COVID-19 pandemic, I also had a part of the advice we on the hospital sports and during the pandemic, I'm not just to get with you that we really just talk about robotic program because a lot of centers and universities in relation to COVID-19 are solved with their program to hold these robotic restart, of course.
Apologies, I think we've had some connection issues, so we're going to reload the presentation.
How my practice from an open cystectomist is now purely robotic with intracorporeal reconstruction angle thrown in, and some work that my research fellows in my lab does based out of the UK and the United States, looking at low pressure robotic cystectomy from the cytokine point of view, and also from the point of view of particulate matter data research, which I'll share with you. Now, robotic cystectomy is pretty much here to stay.
Apologies, everyone. We've had some difficulty with the connection. We've got Mr. Vasdev here, and he will try and present it live from his side. I think we've got some internet issues at the administrative side. Thank you, Nick.
Thanks, Pavan. Can you hear me?
Yes, Nick, we can hear you.
Okay, perfect. Well, I'll start off live if that's all right, because
Perfect.
it sounded like I was having a massive epileptic fit, but that wasn't the case during the recording, I promise. So, well, good afternoon. My name is Nikhil Vasdev, and I'm very grateful to Pavan and to the faculty to invite me to speak on robotic radical cystectomy, the new gold standard. I'm going to be sharing some data as to how, from predominantly being an open cystectomist when I started my career off in 2014 as a consultant, after finishing my fellowship at the City of Hope in LA, and how things have moved on. And I'll share some latest research just to reinforce where we stand with robotic cystectomy. So the entire onus of how robotic cystectomy is evolving in the UK is largely down to patients driving it, patients demanding and asking for it. And I feel that robotic cystectomy from the ablative point of view is important, but also from the point of view of the intracorporeal reconstruction is even more important, because that's where a majority of the complications happen. So my center is the Lister Hospital in Stevenage, which is a part of the East and North Hearts NHS Trust. We are located north of London, and we have a catchment of about 2.6 million. We have two systems in our hospital. We have an XI and an SI with an imminent third system on the way. And we do about 350 to 400 robotic urological procedures per year. I lead the bladder program, and I do about anywhere between 40 to 60 robotic intracorporeal cystectomies per year. We have two Royal College of Surgeons of England fellows. Obviously, Bhavan was one of them who went back to Freeman. And we've had Ashwin Tamankar from Mumbai, and currently we have Arvind Nayak, who is with us. Now, my role during the COVID-19 pandemic, and the reason why I brought this up, was being on the government response team, which I still am a part of, on being an expert advisor on the COVID-19 response. But the reason why I brought this up is that we were able to carry on with our cystectomy program right the way through, and we saw a surge of referrals come through. There was a lot of controversies about aerosol, a lot of controversies about how aerosol and COVID could be an issue, and the evidence was low level, which has fortunately been binned. But I'm going to show you some work that I do up here and in Connecticut with ConMed Surgical to show you some particulate matter research with the context of cystectomy. Now, COVID-19 and cancer has had an impact at the peak of the pandemic. We did see a significant drop in the number of referrals coming through. Obviously, bladder cancer was not hit as much, because if someone has blood in their urine, it's quite an alarming symptom, and patients will come across and seek help. But especially with prostate cancer, the level of referrals did drop. So being a part of the government, we do release commonly in the newspapers in the UK, those of us who lead the response, to tell patients to come forward, because it's not only the UK, but all of you who are on the call from international countries, are aware that we are here to help patients out. So let's just focus now on robotic cystectomy. The fact of the matter lies that patients will bypass non-robotic centers in the UK. And this is translating into an increased demand in robotic systems, new systems being developed and rolled out. But also, this is similar to what happens in India, in Asia, and different countries, where patient demand and patient need will cause you to allow the expansion of a robotic program to take place. And we've seen surge on surge growth with robotic programs both in the UK and obviously in India. So this is a slide of my practice. So essentially, when I started off towards end of 2014 as a consultant, I was predominantly an open cystectomist, but now my entire practice is purely robotic with an intracorporeal angle thrown in. And I do strongly envisage that by Next year, this year I've done 42 cystectomies, all of them with intracorporeal. And I see the reason why this is important to put out is how your practice can transform and how patients can benefit from the technology that you offer with robotic cystectomy. Now, robotic cystectomy has been around since 2000. There's been a lot of talk about it because centers that were offering prostatectomy, nephrectomy, nephroureterectomy, partial nephrectomies started rolling out their programs to do robotic cystectomy with a pelvic lymph node dissection, be it level 1, 2, 3. We then do a level 2. But the reconstruction was still extracorporeal. And I'm sure, Bhavan will touch upon some of the latest evidence that we've written together. But I don't want to overlap on that. But the main problem still is the complication rate and readmission rate is still high for robotic cystectomy or open cystectomy or lap, which is in the vicinity of 1 in 4 patients will come back with some issue or the other between 30 days and 90 days. And that's the reason why we are keen to intercept this problem. And I'll show you some data from the IROC clinical trial that I've got ready for this presentation today. So this is my practice. So essentially, this is a robotic neobladder. I haven't done one for the past 2.5 years. My entire program is intracorporeal. Obviously, the risk of an open operation, this doesn't happen in every patient. I appreciate that. But we have to take into context what this presentation is about. Is it the gold standard? And, there are risks involved when you have a patient who has an open operation done, because you certainly handle a lot of bowel. You do end up with the risk of postoperative pain. You end up with the risk of postoperative wound infection. Whereas this patient of mine on day 10 following a robotic intracorporeal reconstruction looks like this. So it's not only about the operating, but it's also the use of adjuncts intraoperatively, such as low pressure surgery, which we do. So I will operate on a pressure between 8 and 10 for my intracorporeal reconstructions. Obviously, I'm not going to overlap with Bhavan on the talk with the evidence, but whatever randomized control trials have been published as a paper of mine in TAU and Press has been extracorporeal. And again, a comment that I published early on in March 2019 with Jim Cato and John Kelly, looking at the data from the RAZOR trial, was that the evidence certainly indicated that open cystectomy is less expensive, robotic cystectomy has lesser blood loss and a quicker recovery. But my main question on the RAZOR clinical trial, which is a fantastic study from Nikhil Vasdev, who I know very well, it's largely down to the fact that all the reconstructions were extracorporeal, and a lot of the surgeons who were included in their data had only done more than, had done about 10 cystectomies. Now, having had done more than 200 intracorporeal reconstructions, I do feel that the learning curve is fairly steep for this technique. And I'm sure Jeremy from Hong Kong, who I know and who I met, and I've been across to Hong Kong to see how they work, will agree that 10 cases is probably not enough to really have a learning curve with an intracorporeal or a robotic cystectomy angle thrown in. So the main criticism is whether an open approach or an extracorporeal approach really negates the benefit of minimally invasive surgery. This is a paper of mine that was published in BJUI early on this year, in which we looked at HES data from NHS England on 12,625 cystectomies. So this was open, lap, and robotic cystectomy. And when you look at the trend, certainly in about 2013, 10% of patients were having their cystectomies performed via the robotic route. And that figure, as it stands right now, is about 50%. So a year-on-year significant growth. And when we look at some of the outcomes, certainly in the context of robotic cystectomy, the length of stay is slightly lower, from 8 days to 11 days. This is, HES data is very honest, accurate data which is put out. And complication rates are also lower. I don't have a sub-analysis on extracorporeal reconstruction versus intra, but that'll be the next paper that we'll put out shortly. Now, the Cochrane review will obviously be covered by Bhavan in his evidence talk, but the main complications which tend to take place, be it in any type of cystectomy that's done, are predominantly urinary tract infections and ileus, because you are anastomoting gut, you're rejoining gut, so a risk of ileus does persist. And this goes back over many years. These are textbooks which have been published in the past, which is the Urological Clinics of North America, in which the complication rates can vary between 19% to 27% with a neobladder versus 1% to 39% with an ileal conduit. But again, when you zone into the complications which take place, these are predominantly gastrointestinal complications and also UTIs. So we want to work on a program that really reduces ileus and reduces UTIs and ensures that patients do not come back. And even if they do have to come back, we need to evaluate and see how we can use new tools such as AI to predict this. And I'll show you some data on this shortly. Now, my robotic cystectomy program starts off with performing the cystectomy first, then a pelvic lymph node dissection, and then a robotic intracorporeal ileal conduit. The technology that is available with the robotic system, this is predominantly intuitive systems, you can really have a lot of precision surgery which takes place right within the pelvis. So this is a 40-year-old patient who had T2G3 disease with 4 cycles of neoadjuvant chemotherapy. We have about 70% of patients who have neoadjuvant chemotherapy in my network. And you can see that, the precision really allows you to do a thorough pedicle dissection. This patient, 2 years out, is disease-free, is sexually active, and has done really well. Obviously, bladder cancer is a different beast when it comes to oncological outcomes. But certainly, we work towards ensuring that we can really offer patients the best outcomes that we can from a surgical point of view. Length of stay for my ileal conduits intracorporeally is 4 days, and for robotic neobladders is 7 days. So that's the average length of stay that we have. On the right side is a female cystectomy that's been done. Again, we use basic apparatus. Then when we operate, I use the vesi sealer now when I'm doing a non-nerve sparing cystectomy, which really prevents you from applying excessive clips on the pedicles, which makes the operation fairly slick and quick. And you can obviously use staple guns, which I'll show you shortly. Now, this is the positioning that is adapted with the SI system. So I know in India, a lot of the systems are SI. I've done Thailand's first robotic neobladder 2 years ago in 2019. And the SI system, it has a slight advantage because you do a port and port in which you can, with your side port, which you use for stapling, you can basically detach the robotic arm and put it through. So this is something which I would recommend if you do want to start doing robotic cystectomies. We have the XI system in my center, and I use the robotic stapler. I'll show you a video on this right now too, in which basically using the robotic stapler in the past 30 consecutive intracorporeal cases that I've done really has a significant advantage. So it reduces the time, and you as a surgeon on the console has got complete control per se on the stapling applicability during surgery. Now, being a preceptor with CMR, we have also developed a 4-arm protocol with the Versius robot for cystectomy, and we've done intracorporeal reconstruction, ileal conduit. We haven't done neobladder yet. And this protocol has been set up by Phil Charlesworth, who's a colleague of mine. I was coming across to Pune to operate before the pandemic, but hopefully, October is when we plan to do intracorporeal reconstruction. So what I'm trying to say is that it's not only down to the intuitive robot, be it the SI, the XI system, or the X system. You do also have stronger contenders such as CMR with the Versius robot coming through, which will help you adapt on a 4-arm CMR cystectomy. So it's not only about, the robotic tech, but certainly the integrated table, which we use, especially during intracorporeal neobladders, really does help, in which you do not have to de-dock during surgery. All you need to do is move the patient with the table attached. So this really helps you mobilize your ileum, which you're trying to join up with the urethra for your robotic intracorporeal neobladder. So again, small steps, small technology with a significant benefit to patients to allow you to operate in a better manner. Now, criticism with robotic cystectomy largely used to be the problem with a stricture on the left side due to traction, due to mobilization. But the key is to ensure that you follow the same principles that you normally do in the context of open surgery or laparoscopic surgery by maintaining the main vessels which are coming off the common iliac to the ureter. And you can see that's the ureter coming behind the sigmoid. Now, what I have started doing with my intracorporeal reconstructions, be it in the context of an ileal conduit or ileal neobladder, which is a modified Studer neobladder, is I use ICG, which I think is a real game changer with your vascular anatomy recognition to see what's going on. So this is a standard ureteric mobilization that I will do. I think the principles need to be maintained of using short bursts of diathermy to prevent any thermal injury to your ureter. Obviously, my fellows have been trained and I'm very, very pedantic intraoperatively on handling of the ureter intraoperatively. But you can see, just by gentle traction, I don't use loops anymore. By using short bursts of bipolar diathermy, you can very nicely control the feeding vessels which are coming in. So you don't have to open up more vesi sealers or excessive clipping, etc. Just by nice control with some pneumoperitoneum being at about 10, you can achieve these steps. So intraoperatively, all patients will have their ureter sent across for a frozen section analysis on the left and the right. And once you come up to the level of the iliacs, you really want to avoid damaging the proximal pedicle coming off the common iliac artery on the left side. While attempting to cross the ureter behind the sigmoid, again, be careful, be gentle. But the reinforcement is, the talk is about robotic cystectomy being the gold standard, but it's largely down to how you operate also. It's not all about the robot. You need to have basic principles that you follow with tissue traction, ensuring that you don't end up damaging tissue because the robot has no haptic feedback. So this is just going to demonstrate to you the intact pedicle coming off the common. And you also want to ensure that there is no kinking of the ureter intraoperatively. Now, ICG is given approximately 2 to 3 minutes before I do the ureteric dissection. But to evaluate the vascularity, you can see with ICG, you can really accurately pick up the vascularity of the ureters intraoperatively. So you do not want to cut into ischemic areas. You can see the proximal points of the ureters are very, very ischemic, but you can see a nice blood supply demonstration on the left and the right ureter before the intracorporeal ileal conduit is what I did in this patient to take place. And again, bowel anatomy recognition is very useful with ICG too. Now, intraoperatively, I do use the robotic staple gun now in the past 30 cases. Again, I just want to demonstrate some steps that we tend to do with the robotic stapler. It has a bit of a learning curve because it has fairly rapid action, rapid movements which can happen. So this is an ileal conduit being constructed, and this is the robotic stapler being used. The advantage of the robotic stapler is that you as a surgeon operating on the console have total control to see what's going on. And you can use a 60 millimeter cartridge or a 45 millimeter cartridge. I prefer a 60 personally because I think you can take bigger bites through it. And these are obviously staple guns which are being used, which is a blue cartridge instead of the white cartridge. White cartridges you can use onto the pedicles. So I use this for my intracorporeal neobladders and my conduits, and I think this has really made the process a little bit quicker. So just some data, which is always very nice to be open and honest. So I compared 100 of my open ileal conduits with the 107 ileal conduits that I've run robotically. My stricture rate is slightly higher on the robotic series. Left-sided strictures are common. But the way I manage these is an nephrectomy in 3 patients, with 3 having an open reimplantation and 1 having a robotic reimplantation. But I haven't got data on ICG because ICG I've only used in 11 patients so far. But so far things look pretty positive and good. Now, it's important not only to talk about robotic cystectomy, it's also important to see how we can improve robotic cystectomy further. So my interest in my research laboratory is to do with the evaluation of ileus using cytokines. This is the paper which is currently available on PubMed, in which we compared pressure of 12 versus 15 in prostates. Now, in prostates, we don't tend to see ileus that commonly. But the reason why I developed this protocol was largely to see if cytokines would be different. And what we found was that gut cytokines, which indicate ischemia, are higher at a higher pressure and lower at a lower pressure. Now, this has also been translated. We've just submitted this to JU Roll. And I'm grateful to John Pirad, my research fellow, who's been working with me on the project, in which we randomized patients on a one-to-one randomization from a pressure to 12 to 15. Oncologically, neoadjuvant chemotherapy-wise, T-stage-wise, everything was fairly stable. But if you look down here on the outcomes of patients between 12 versus 15, we found that the risk of ileus was lower at a lower pressure. The length of stay was lower when you had a lower pressure. And certainly the readmission rates were also lower. So early data reinforcing low pressure being the way forward. I don't have cytokine data yet, but I'll be presenting that as a plenary at the AUA next year. Now, the COVID-19 pandemic is amongst us. We had a situation in which we did not know whether we should stop operating or not. A lot of hospitals in our region last year did stop operating. And being on the Trust Executive Board, I was able to liaise with my senior executive team, evaluate what was taking place, and we decided to push on with our robotic cystectomy program. So we developed protocols to allow us to operate. These were using very, very tight apertures with your ports. Again, making sure that there was no leak. I was operating at a pressure of 6 to 8. And using the air seal device is what we managed to achieve as far as safety of patients was concerned. Also, what we used to do was we were closing all the ports, but the last slide indicates the use of a Buffalo filter that we're using. But what we found was that in patients that we did about 345 patients through the pandemic, and we had 0% COVID post-surgery at 30 days, again, reconfirming the safety of robotic surgery in the context of the ongoing pandemic. We obviously collaborated and published this in European Urology early on this year, in which we found that the risk of COVID-19 post-operatively in 599 cases was fairly low. Now, I'm just going to spend a few more minutes on particulate matter data research, which my lab at the University of Hertfordshire leads up here, and we collaborate with the US and Connecticut. But the air seal device largely, is basically a gas equilibrium port in which you have different barriers, a different smoke filter per se. So what we did was we set up some basic experiments in which we set up a bladder cavity, and we did a lot of AI work on the ports to see where the flows were through the port. And the setup essentially is a diathermy machine, a TSI, particulate sizer, to capture data on all ports to see the degree of leak. And I'm just going to show you a video of what we do, because we're trying to mimic the instrument moving in and out of the patient intraoperatively. So this is just a video to demonstrate what we tend to do. So you can see down here that I have got an instrument going in and out. This is an accelerator device which allows us to gather intelligence and information on particulate matter leakage intraoperatively, because the controversy is that with an air seal device, if you put an instrument in and take it out, whether you will disseminate gas all of a sudden with the risk of COVID-19 particles being lodged all of a sudden. So this is what we tended to do. And what we found on our experiments that we've conducted very successfully, which is again in press right now, is that the usage of low pressure with a buffalo filter can really clear your entire abdominal cavity in about 3.5 minutes with a clearance of 95% of particles. And again, this is obviously complicated data. I don't have time to present all this today, but we've compared low versus high pressure, again, reinforcing low pressure to be the way forward, which has been seen in the clinical context to improve patient outcomes, but more importantly, from the safety point of view, is also important to consider. So just to conclude with a few more slides. So this is the IROC clinical trial on which I'm a principal investigator with Jim Cato and John Kelly. This is a trial comparing open versus robotic with intracorporeal reconstruction. And we are using a little bit of AI with DreamPath technology intraoperatively for these patients and postoperatively. Essentially, anybody who has a cystectomy has a fitness tracker, which is an Apple Watch, which is a medical Apple Watch, in which you will have tracking take place at different time frame or intervals at 5 weeks, 3 months, 6 months, and 1 year. And what we found is that patients whose fitness kind of drops off at about a month all get readmitted with a complication. So this is the data coming out from AI. So hence we are trying to intercept and ensure that patients who are pretty fit before surgery, who don't probably be as fit after surgery, after major surgery, we're trying to ensure that we work towards a fitness regimen to prevent them from getting less fit so they don't have a complication. So that's where robotic cystectomy is fitting in. We've also looked and compared to see if AI data from your fitness trackers can predict mortality. Absolutely it can. Not only in the context of overall survival, but disease-free survival, both can be predicted. And we've also looked to compare the Apple Watch data to your CPET testing preoperatively. And that's something which we're working on the step count to strongly correlate with the CPET variable. So the fitter someone is, the better they do. And that's the way forward. So just to conclude off, the IROC clinical trial will obviously help us understand whether intracorporeal reconstruction is really the way forward. Current evidence for cystectomy supports lower blood loss, lower length of stay with robotic cystectomy. Early functional and oncological outcomes with intracorporeal reconstruction are very, very reassuring. The operating surgeon, without a shadow of a doubt, is a very important factor. So if someone has done 4 cystectomies and someone has done 200 cystectomies, there will be an outcome difference because it's a steep learning curve. But again, all steps have to be followed thoroughly from the oncological point of view, because a positive margin in a cystectomy, be it in the context of open robotic or lap, is non-forgiving because patients will develop a disease recurrence. So follow the principles to the hilt with all 3 steps with cystectomy. And again, newer systems coming out, the CMR system coming out, new technology will improve outcomes further with robotic cystectomy, because I feel it's very much in its infancy right now with a tremendous amount of potential to put in, especially when you throw a little bit of AI and integrated technology. So I just want to acknowledge Carol Takastika, who's a friend, colleague, Jeremy from Hong Kong, Pavan Rai, Alex Motri, Mahendra Mandari, Professor Das Gupta, and Tim Lane, my colleague. Thank you very much.
Thank you very much, Nick, for that excellent talk, giving a strong case for robotic radical.
Pavan, I think you're on mute.
Am I on mute? Can you hear me? Giving a very strong case for robotic radical cystectomy. Obviously, there are arguments for open radical